Okay, so hi everyone. Thank you for your time and invitation to present at this, our final annual meeting. Again, my name is Catherine Hensly. I'll be presenting the toll and rewards of family caregiving, elder care in South Korea. Slight title revision to what was originally published in the program. And this is a project, it's a collaboration between Jiwon, Beth, and myself. So in a rapidly aging population such as South Korea's, an increasing number of family members really find themselves faced with hard decisions about how to care for aging parents or other relatives and are assuming ever greater caregiving responsibilities. The population pyramids here illustrate how the population profile of South Korea has really changed in the past several decades in terms of its age concentration to underscore this point. In fewer than 100 years, the median age of the population increased from about age 19 in 1950 to to 44 years in 2020 is projected to increase even further to 57 by 2050. So this has been driven by a combination of a rapid increase in the average life expectancy at birth from 48 years in the 50s to 81 years in the late aughts, along with a steep decline in fertility from 5 births per year per woman in 1950 to just about 1 birth per woman in 2018. So this dramatic demographic transformation really necessitates some kind of structural change in care provision that has to take into account Korea's rapid industrialization and urbanization on the one hand, alongside social and cultural norms about the family on the other. So even as a growing share of care responsibilities are borne by paid caregivers at home or in care centers, there's still this large share that has to be met through family caregiving. Maintaining the quality of life of these informal and unpaid family caregivers is really important for at least a couple of reasons, which I highlight here. So first, Miller et al. Find that decreases in informal caregivers' cognitive ability may reduce the quality of care that they provide. And similarly, Smith et al. Find that depression levels in caregivers can be predictive of increased frequencies of potentially harmful behaviors directed towards the care recipients. At the same time, there's also a need to minimize the health and mental risks to caregivers on their own so that they can return to previous employment after providing care as applicable. So for instance, Van Houtven et al. Find that informal caregiving reduces formal labor market participation, both on the extensive and intensive margins. And Batrika and Karamcheva find these effects vary by type and amount of care provided. So it's important to examine really how informal care responsibilities are impacting the lives of these unpaid care workers. With this in mind, this paper focuses on the psychic or mental and physical burden alongside opportunity costs of caregiving within a family. And this toll, along with the psychic reward related to the satisfaction from being a caregiver, directly impact the quality of life of the unpaid family caregiver. The greater the toll, the poorer the caregiver feels about their quality of life. Quality of life thus depends on balancing this toll and the reward realized from caregiving. Understanding these effects and what contributes to this toll can help ensure that these caregivers also have cost-effective health and social care support services and pathways from more of a policy standpoint. So just very briefly, there's a huge body of literature on elder care provision and the corresponding burden to caregivers. And one recurring theme is that it's extremely challenging to identify the factors that most influence the burden experienced by caregivers, let alone define and measure them. Very briefly, the literature highlights how family caregivers are likely to face many stressors related to care provisioning, which includes some of the ones highlighted on the slide. And then these stressors contribute to the toll extracted from the caregiver, in particular, the mental or psychic health, incidents of increased depression, as well as the physical health and overall quality of life. Although caregiving imposes significant toll on the caregivers, there's also the expected returns or reward from caregiving. So in particular, I just want to highlight Doe et al. Examining the role of social and cultural norms on caregiving, and then how those norms are linked to expected benefits for the caregiver in the South Korean context. Drawing all of this literature together is what brings us to our conceptual framework. And so for our paper, in our model, we propose this type of approach, that the quality of life of the caregiver is given as a function of the toll and reward to caregiving, a vector of control variables and a random error vector, which isn't shown here. The toll encapsulates both a psychic or mental toll, physical burden, as well as opportunity costs. And those opportunity costs can be separated further into, on the one hand, a financial component, as well as a temporal nature with respect to time for other care or household production. We use the 2018 CareWork Family Survey in South Korea, which I will talk more about in just a moment. For now, I'll highlight the survey affords kind of the following questions and responses, which we apply as measures of the collective toll and reward. So first, quality of life is asked as how satisfied are you with your life in general? And this is asked independently of its relationship to care provision. And then this can be classified as dissatisfied, neutral, or satisfied. The psychic or mental toll is asked how much stress is reported due to taking care of the elderly. Is it not stressful, normal, or stressful? Physical burden, how much physical strain is reported due to caregiving? Is it not difficult or normal, slightly difficult, or very difficult? Again, opportunity costs are divided between the financial component, whether the respondent's financial situation has worsened compared to when care began. It's a yes or no. On the other hand, with that temporal component, whether the caregiver respondent lacks time to provide other care or do housework due to providing elder care. Disagree, neutral, or agree. So 3-type response. And then finally, that psychic reward. Is care provision fulfilling or rewarding? How is that perceived? Disagree, neutral, or agree. To estimate these relationships, we use a generalized structural equations model. It relies on maximum likelihood estimation and allows us to test hypotheses about the relationships between these variables. So again, the tolls and reward are observed endogenous variables, which are functions of the characteristics of the elderly care recipient. These are given in the boxes. So the tolls include the mental and physical status of that elderly care recipient. So the mental status is measured in terms of a dementia score, and the physical status is measured in terms of the number of activities an elderly care recipient can perform independently. On the other hand, the reward includes the caregiver's familial relationship with the care recipient, going back to that brief note on the literature from Doe et al. So whether that relationship is characterized as being the spouse to the caregiver is the spouse of the care recipient, whether that caregiver is the biological child of the care recipient, or whether that caregiver is a child-in-law of the care recipient. While we explored how age of the elderly care recipient may enter into this, ultimately we don't include it here since the effects on those tolls are really tied to that physical and mental independence, and those correlate with age, but rather than focusing on age itself. The tolls are assumed to be related, and so the error terms for these four equations, for that psychic mental toll, the physical burden, and the financial and kind of temporal opportunity costs, those error terms are specified to covary with each other. And then finally, up in that kind of upper right-hand corner of this slide, we include control variables with respect to the caregiver themselves and the household for that quality of life of the caregiver equation. So this includes gender, age, and a quadratic for age, employment status, household income quintile, the metro status of where they're living, whether children under the age of 18 are present, and then the overall household size. So more formally, the estimation model, because the sample is relatively small, we estimate just a simple structural model using in order probit estimation for the quality of life, again, dissatisfied, neutral, or satisfied. And the probability of a given response is a function of the toll, C, and reward, R, as well as controls, vector X. That vector X, again, is assumed to pertain to the characteristics of the caregiver, that age, gender, income, wealth status, etc. C and R, the toll and reward, are functions of Z and Y variables. As was illustrated on the last slide, we assume that these include only the characteristics of the elderly care recipient themselves, whereas that X, again, in the quality of life function, pertains to the characteristics of the caregiver and that caregiver's household. So in other words, Z pertains to the measures of the mental and physical status of the elderly, as these will affect the cost of caregiving, which are not assumed to be directly related to quality of life of the caregiver, except through their effect on the cost or on the toll itself. Y then includes the type of relationship of the caregiver to the elder care recipient, which likely influences the presence or absence of an effective relationship between them. So whether members of the household have expressed gratitude or affirmation to the caregiver is another input into that caregiver's feeling of being rewarded. So I mentioned I would talk a little bit very briefly on the data. For our estimation, we're using that 2018 Care Work Family Survey in Korea, and that really affords this richness of information on caregivers, care recipients, household arrangements, and physical, psychic, or mental and economic tolls incurred to the caregivers. In total, there were 501 informal elder care provider respondents within this survey. Elderly encapsulates those that are age 65 or older, those recipients who need help in maintaining daily life due to frailty or sickness. And these are primary caregivers that are responding. They're either co-resident with the care recipient or visiting 3 times a week or more and at least 2 hours per visit if non-resident. The graph on the right-hand side just depicts the distribution of that general life satisfaction response, which is what we're using to measure quality of life. So whether dissatisfied, neutral, or satisfied. To characterize the caregiver and their household, we present here just a few selected summary statistics. Standard deviations are reported in brackets for continuous variables, and all of these values are reported using the corresponding analytic weights that are provided in the survey itself. So we can see that for the caregivers, the average age is around 57. They're predominantly female, mostly married or in a couple. Slightly fewer than a third are employed or report being on leave, but are still employed. We can see the distribution of relationship to the elderly care recipient, the distribution of where they're living in terms of locality, whether that's a metropolitan area, small or medium-sized city or county. Only about 16% of households actually had children, dependent children, 18 or younger present. We did check, there's only 8 households that had young children aged 6 or under. So we focus kind of more broadly on the dependent children as our control, instead of worrying about the small number of 8 out of 501. Average household size is about 3. And then that last point of also uses professional care of about a third, that was asked in the survey as, do you use any public or private external care services or institutions to care for the elderly person? About a third do, in addition to providing the informal care themselves. And that likelihood does increase relative to dementia status. Which brings us to a brief look at our elderly care recipients. Again, few selected summary statistics, standard deviations in brackets for continuous variables, using analytic weights applied in this survey. A couple of things to note here is that, again, what we're focusing on here too is the mental status and physical status. So physical status refers to the number of activities that the elderly person can perform. These include things like preparing and eating meals or drinks, taking care of personal hygiene, using the bathroom independently, dressing appropriately, etc. If the elderly person could perform 6 or more of the total listed activities, their care providers were excluded from the survey, so it had to be 5 or fewer. And we can see here that the mean is right around 2.4, 2.5. Moving on to the results, our preliminary estimation results yield the following. And rather than present full tables, I've excerpted some of the key findings here as they pertain to the individual tools and reward. These are coefficients of linear probability results. So I'll talk through these just kind of briefly here, that we can see the living arrangement, meaning that the care recipient is living with someone else other than the caregiver, has a negative effect on this psychic or mental toll. Having mild dementia contrasted with not having dementia at all increases that psychic or mental toll. And the number of activities that are able to be performed independently has a negative effect on the psychic or mental toll, meaning that the more physical independence that elderly care recipient has, the lower that psychic or mental toll incurred on the care provider, caregiver rather. Physical burden, we can see that if the elderly care recipient's gender is female, that lowers that overall physical burden. Again, dementia contrasted with not having mild dementia contrasted with not having dementia increases that physical burden. Independent physical activities reduce it ever so slightly. And hours of care provided per week has a slight positive effect on the physical burden realized. In terms of the financial status worsening, physical activities, physical status of the care recipient, increased number of activities able to be performed, decreases the likelihood of a worsened financial status. Mild dementia or even moderate to severe dementia has a positive effect on the likelihood of reporting no time for other care or household production. Similarly, increased physical independence reduces that. So it's kind of a double negative, that the more physical independence the care recipient has, the less likely there's no time for other care or household production on the care provider side. The psychic reward, again, we see living arrangement. If the care recipient, the elderly care recipient is living with someone else, that reduces that psychic reward on the part of the care provider versus if, they're co-residents with each other. If the caregiver is a biological child, that has a positive effect on the psychic reward realized, and that use of that external care services, professional care also enters positively to that psychic reward as well. In terms of then how these tolls and reward roll up to the quality of life itself, very briefly here, right now, these are coefficients of the ordered probit run as part of that GSEM model. So we'll focus just kind of very briefly on the signing that the tolls, of course, enter negatively and that reward enters positively. Although I will note that that opportunity cost in terms of time for other care and household production is not significant at the 10% level, but the other three tolls are, as well as the reward. So just to wrap up, make sure I'm staying on time here. Our immediate next steps for the paper include refining that GSEM model, computing the marginal effects in terms of cognitive and physical status, i.e. the dementia rating and number of independent activities able to be performed. But for now, to sum up our initial findings and provide some brief policy context, the kinship ties really can produce more affectionate and effective care. Caring for family members is still shown to incur a heavy toll on the caregiver. So that said, the caregivers themselves require care and support, and this can be achieved through things like promoting training programs to increase competence and confidence of family caregivers, otherwise lacking in that formal training in caring for that elderly relative, establishing psychosocial support programs for those caregivers, and developing post-caregiving support programs, such as when returning to formal employment from full-time informal caregiving, particularly as that affects to individual identities. So I will leave with this. Thank you so much for your time. If you have any specific questions that I can address, I can do so now. If not, I will pass on to our next presenter.